Cool. Thanks. This is the talk one of my registrars put together for me. I do a lot of some surgical procedures. One of my interests lately is to deal with fibroids. I don't know, it's because I'm an African man. They know that fibroids occur mainly in Africans, Asians, and Indians. There's a few in Europeans as well. But somehow I've ended up dealing with a lot of the fibroids in my department. So fibroids, and they are benign, they're not cancer, but they can be cancer. So not all fibroids are normal. Very rarely you can find leiomyosarcomas. So you just need to satisfy yourself that before you remove them, they are not a cancer type. So one of the things that we've been doing in the past, is anyone who's got fibroids, go under the knife, they get a hysterectomy. Also in the past, they just say it's not going to work because trying to remove all of them, you're going to bleed and bleed and bleed and bleed and end up doing hysterectomy anyway. So one of the things that we've moved to doing is using vasopressin. Vasopressin is a drug that helps. I don't know what they call it here. What's the kitchen name for vasopressin? Um, it's a little bit, yeah, but it's a vasoconstrictor. Yeah, Pitocin. Yeah. Pitocin, yeah. So it's a vasoconstrictor that we find pretty useful when you're dealing with fibroids. So just a few things. This is the little talk I'm talking about. Um, so vasopressin comes from the hypothalamus. I'm not going to bore you with this because this can be just taken straight from the books. Um, but it occurs naturally in your body, but it can be synthesized and then you can give it to the patient into the capsule of the fibroid. This is the chemical makeup of it. Those who are chemical chemistry fundies, that is the chemical makeup of it. But I'm not interested in that. Um, the last part of it says the half-life is 10 to 20 minutes. That's very important for me when I'm doing my surgery to know how much is in the patient's body while I'm operating. Um, so myomectomy is removal of the fibroids. So we do remove fibroids. If you're 50 and you come to me and say, I want to have my fibroids removed, I'm going to say no because there is no reason to keep the uterus after 50. So you need to see if the indication sorted properly. If somebody is 30 and they're trying to get pregnant, they lose a baby, get pregnant, lose a baby, then there's an indication that we can do something for you. So those are the ones that we choose who are still trying to fall pregnant. If they've got children, they don't want to lose their womb, they're still babies, they just want to reduce the bleeding, we can also do that for them. You can shrink the fibroids with generate analogs or allopurinol acetate prior to going for a theater. Or you can take them to interventional radiology where they put some coils to block the uterine arteries that are supplying the uterus. That starves the fibroid of blood and then they will shrink in size. They don't disappear. There's a newer version of treatment called MRGFUS. It's using ultrasound to burn the fibroids. Do you guys use it in ultrasound? Yeah. So there's quite a lot of things. So my particular interest is more on the surgical part because it's not easy to tell whether ultrasound or embolization is good for future pregnancies, but we know from surgical point of view that it's much better for future pregnancies. Um, because embolization is quite common now in it, we have to compare which one is better. At 1 year, the quality of life um, for both patients will be the same. But at 2 years, you start getting better quality of life from the ones who had the surgery than the ones who had the embolization. I think that's probably one of the things that made us decide that it's probably better to offer surgery if you've got the skill. If there's no skill, take them to the interventional radiologist. They will do their parts. Or if the woman is 200 kilograms, and if you don't want us to operate on her, send them to interventional radiology. So these are the cases that I've done. This is the first case. No, it doesn't go. Oh, you one point there. This is right. I mean, I think you can appreciate this is the pelvis of a lady. This is the fibroids. The uterus is like that. It's pretty enlarged. The endometrial cavity is tortuous, going like that. So this woman came and asked me that I want to have more children, to have children. Obviously, there's no place for the baby to implant here. So because they are quite large, they're up to the sacrum there. So we did do a funnel still. Once it goes above the sacrum, I tend to do a midline laparoscopy. We did do a funnel still here and remove the fibroids number 1, 2, 3, 4. And then I did a scan 3 months later. This is the uterus now. And she's got normal periods, and I said you have to wait for a year before you try for a baby because I don't want the baby to disrupt all the work of that. So from that to that in 3 months. If you were to put them for embolization, you probably could reduce this to another size, but you can't reach all of them. But you're able to squeeze all of them out and give the patient a better outcome. You can see this fibroid number 3 here. It's pressing on the bladder here. So she'll be going to toilet every day. It starts to fill up, she wants to go. It starts to fill up. And the one at the back is pressing right on the rectum. So constipation, urinary frequency were a big problem for her, and period problems and can't have children. Just major things that are important for her. So we performed the surgery for her, and she had a very good outcome. Blood loss in this procedure was about 200 mils. Let me see if I'm right. Blood loss, I know, I think it was 200 mils. This is a Chinese lady. No, I did a midline, forgot, sorry. And um, the maximum size of the fibroid, the biggest one was about 8 centimeters. So they're not small, like 8, 5, 6, 4. Big fibroids. So the next case is another lady that we did a similar procedure. For this one, we did it laparoscopically. So we didn't cut it open, we did laparoscopically. So the fibroid is sitting right at the fundus, but more posteriorly, leaning back on the sacrum. This is the sacrum. So this is the fibroid sitting there. It's pulled the whole cervix up here. This is where the cervix starts. Endometrium is probably going to be somewhere here. So we did it laparoscopically, and then I think 3 or 4 months later we did the scan. This is a nice uterus with no fibroid. The fibroid has been sitting here. A nice, normal, having normal periods now. Yeah, so this was done in laparoscopic approach, 100 mils of blood loss. So when you are removing this, you inject the vasopressin right at the capsule of the fibroid, and then we use something we called an ace harmonic, which is an ultrasound type of a knife, a cutter that opens up the capsule, and then you scoop it out, and then you close the gaps, the cavity inside using barb suture. Barb suture is suture that goes one direction, because if you put it back, it doesn't go back. So it's a one direction, it holds everything together. And that took us about 2 hours to do. And she's having good periods and is trying to get pregnant as well. So when it says there's a person 3 units, it just means that out of the 20, the MQ comes in 20 units. So we'll probably use 3 of those 20. We don't need to use a lot. The anesthetists usually get very scared because one of the side effects, if you put it into the bloodstream, you can get some cardiac effects. Just make sure you don't put it into a vein or an artery, just into the capsule of the fibroid. Next one. This is another one. That was a nightmare. I mean, if you look at it, um, this is an MRI scan, getting a sort of a cross section, corner section. You can see this is the back, this is the spine. Um, this is one of the fibroids. This is probably another fibroid. There's probably a bit of endometrium here, and multiple other fibroids that were sitting there. Massive, massive uterus. Some of these things just freaked me out. I was like, "Oh, why did I even agree to do this?" Because if they lose the uterus, I'm going to be in trouble. But I promised them we're not going to lose the uterus. I don't have a follow-up picture of it, but it went well. But it was an open case. Um, yeah, we started laparoscopy, then ended up with an open. One of the things that we did differently is that the fibroids that show up inside the endometrium will come from down below through the cervix and use this instrument called the myosure. It helps to chew the fibroid bits and bits, chews and spits out until you've taken, you can take a good 4 centimeter fibroid out. But once you get more than that, it gets blunt and you have to throw it and put a new one. But it costs about $1,500, so you don't just use them lightly. But it helped us to remove the ones that were protruding inside the endometrium. Then the rest of them we remove it from the top with the laparoscopy. So these are pretty large fibroids. If you look at the size, number 9. Um, this one was an interesting case. You know, sometimes you get used. And trouble with us surgeons is that we get very cocky. We think now I can do anything and everything. And then they referred to me this case and said, here's another lady with a big uterus and multiple fibroids. She wants to conserve the uterus. And they say, okay, we're going to do it. And we take her to theater. And then we find something like that. Can somebody hazard to guess what that is? What have encircled? Any guess? Any guess? When a guess means it can be right or wrong. Just guess. So what we found was these are adenomyomas. So they're very tricky to differentiate because they're not fibroids. There was a fibroid which was small, but those circle things were adenomyomas. That means if someone has got adenomyosis of the uterus, there is no delineation that this is now bad, this is now good. It's just messed up with the myometrium of the uterus. It really caused us a lot of grief. We managed to remove it. This is the hardest thing you can do in gynae surgery, removing adenomyomas. But we managed to do, and she's doing well. But next time I know I will screen for this because it's just something that is not easy to do. But it looks like fibroids. It was reported as fibroids by the radiologist, but it is not. Number 5. Here's another interesting one. Um, this lady was Indian lady. Yeah. So she had 3 massive fibroids. You can see them. There's one big one here, the next one here, the next one there. The whole uterus is occupied by fibroids. She said, I want to have children. I mean, this is like massive, massive fibroids. Um, you can see the sacrum stops here, where the pelvic brim stops, and it's gone up, um, above the belly button. I think belly button was somewhere here. It's gone above the belly button. So we did do a midline to remove it, and then we had 4 months later. This was a non-suture that she had. And the periods had gone back to normal. One of the concerns from the past research was that if you do such cases and the endometrium is opened up in the process, it might make it harder for them to get pregnant next time. Or if they do, they are likely to get into issues of abruption during pregnancy. So for me, I don't care much about that, especially because the periods come back, they get pregnant. All I do is that you cannot labor with this. You just have to do a cesarean section between 36 and 37 weeks. No questions. Because if you start pushing things, the uterus has been cut so many times, you're not going to have a life baby because once you go into labor, it's just going to rip everything apart. So they all get cesarean sections after they proceed. This is another one interesting one that had one single fibroid, a massive, massive, massive fibroid. She's an Indian lady. Um, she wanted to keep the uterus. This is called part of the endometrium showing up in the middle of it. And then it's sitting right at the fundus, like massive, massive fibroid. And after removing it, this is what we have, a nice normal uterus. And she's also doing well. I think when I come back in 3 years, I'll present you the outcomes of fertility, how many have had children, how were the outcomes, and how did it go. The last case is this particular one. Very hard to see with a very poor scanner. But this is a calcified fibroid. You can see it here. I think the vagina is somewhere here. It's an ultrasound scan, it's not an MRI or CT scan. Um, she does have a follow-up scan which was normal. I didn't have it here. But it was a massive fundal fibroid that we did, and she went home the next day. So those are generally things that I do as part of my work in the department. I'll do them in public, also in private. Thing is, in private, if you do it, you get paid more. Public, you don't get a salary because it's the same. But it's a few little things that you get interested in, and then you just get more and more cases. Like the laparoscope, you get more and more cases. Just as I'm here, just one of my other patients says, I can't wait to come back and do my procedure. I'm doing one on the second, which is in 2 weeks, huh? A hysterectomy that I'm going to do for somebody. But laparoscopy in private, everyone wants laparoscopy. You can't cut them open; they'll go down next door to your neighbor. So you do everything telescopically. Um, Part of my mentioning this was that I spoke to the senior medical officer in Mabane and the PS and directors. I said, my unit has all these instruments. Sometimes after so many uses, we let them go. We give it to the Pacific Islands, to Fiji, to Samoa, to others. They said to me, they can send them here, and so long as the government here is willing to pay for the shipment, but they can send them here. And I said, well, if they're allowed to pay for shipment, I can come and help people use them, those who have used them, and just at a time of in service. I heard that they say you do a lot of laparoscopy too. Yeah. So those are things that are an option that we can, in future, I said to them, I'm quite keen and my unit is keen. So long as they're keen to ship the stuff over here, then we'll set them up. Who knows? I don't know. Things go a little bit slower, yeah? Much slower. Thank you. That's about it for today. Any comments, any questions?
Any additions, queries, comments? Was it a good lecture? Yes. So we're expecting the 3-year follow-up lecturing. But it's a long time, 3 years.
Yeah, I'm sure there'll be a new lot of teams up.
Everyone happy? Everyone happy? Or tired? Probably
So,
tired.
so no one's going to ask me, how do we get to New Zealand? Hmm? But it's slightly different from the people. Yeah. But I want to find out what the rules of experience. The role of surgical evacuation for women with miscarriage and fibroids. Is it a practice that is done or for the medical? People who've got fibroids with a miscarriage. That's surgical evacuation. We tend to offer medical for a lot of women now. Surgical now becomes if they're septic or they failed medical. Because if you do surgical evacuation of women with fibroids, you need to have an ultrasound guided, somebody doing ultrasound showing you how what you're evacuating. Because it's harder, you can miss things. There's so many bedrooms inside the uterus that's got fibroids. So if you do it without an ultrasound, you're going to miss something. Instead, when you do it, have an ultrasound scan, fill up the bladder so you can have an acoustic window. And then you can see what you are sucking out directly. But if you do medical, uterus is strong enough to squeeze quite a lot of things, even if they're fibroids. Fortunately, they don't get pregnant too frequently, but when it happens, you're better off sometimes medical first. Go for surgery if you have to, because it's not easy.
And I think that question that you brought up.
Uh, um, how do you get to New Zealand? I think you just apply. Just apply. I said something when we arrived in New Zealand in 2005. I said to somebody, they said, how did you come here? I said, we got lost. And then one of my daughters, she was 2.5. So every time they were asking me, she said, Dad said we got lost. Dad said we got lost. I had to correct that. I said, never got lost. We just went. I think the honest truth was that we just wanted an overseas experience. We decided, let's try New Zealand, let's try Australia. A lot of my friends went to the UK, and um, when we got there, and we sort of liked the place, and they liked us, and they say the rest is history. They just said, they stay here, you get to train. Training for specialist there is free. It's free, so you don't have to pay anything. So, in fact, if you've got costs related to your training, like the exam fee, you've got conference fee, or presenting it, they will pay you back. When you go there, come back, you claim back your money. So you really support your training. So you don't feel disadvantaged that I'm doing training. They will train you free. But you have to agree to be a permanent resident. You can't be a visitor, or you have to say, I agree to be a New Zealand permanent resident, or we want to be a citizen. But both of them, then you get free training. The whole 6 years of training on G is free. So you pay for it. Yeah. But I think the bigger issue becomes sometimes is they're very strict on the English proficiency, like your two ITP test, and they're very big on your undergraduates. They're very picky who they pick, but everyone has done USMLEs. If you pass USMLEs wherever you graduated, you've passed that, they think you're a good enough doctor. Then they'll let you in. I would say if you try and see whether yours is recognized by them, if they don't, and you just go and study USMLEs or the GS, the UK, I think is it, what's it called? Yeah, they've got a few little exams. So I would say if you did USMLE, US Licensing Medical Examinations, or and you do an English exam, if you pass those two, you can almost go to New Zealand, Australia, UK, Canada, US without any problems. But USMLE is quite a tough exam. But because you guys are fresh, you still have a fresh anatomy, fresh physiology, it will be easier for you. You just write it, you pretend you're writing your final year exam, and when you pass it, it opens doors for a lot of people. The people who do training in Russia, as they write their exams for final year, they also write their exams for USMLE. So when you finish, you pass them both, and then you just apply to the more for USMLE as well. So yeah, as you understand medical terms, they opens doors for you. I think for me it was easy because at that time I think there were still nicer people in New Zealand. They didn't think about all those things. They just looked at your skill and take you for a while. But now they're but it's possible. I'm sure they don't want you to all go there, but you are welcome. I feel like I need more people of color then to come to my departments. I've posted a few people who come for exchange programs. They come stay with us for 2 or 3 months in the departments, just familiarize them with the unit and what we do, and you get contact, you get to know the area before that you want to work. So, cool. Thank you.
Thank you. So Dr. Leo has USML experience, so maybe Dr. Leo can share with us one day. And maybe you'll find some a Maswati there
Yeah,
over at your place one day.
yeah. Because I'm the only one so far.
You're the only one. So it must be lonely.
It is very lonely. There are people from all over Southern Africa, but from Swaziland, there's only about altogether in the whole country, 5 million, only about seven. So it's not a lot. It's not a lot. Sometimes I lie, I say I come from Switzerland. Because they know, we say Swaziland, they say, what? Where? Where is that? Yeah, Switzerland is nice.
You don't French anyway, so.
Yeah, I know. Otherwise, thanks for having me, everyone. I appreciate your time. And I know it's a hot, long day, but
Okay, just before we, yes.
not fun.
Before we end, make some announcements. So at the end, could the each show interns remain behind for discussions? Okay, do we have any other last minute questions, announcements? Next week, the conference is by Professor Park on hepatocellular carcinoma. Okay, so we'll see you next week. Okay, so thank you once again.